Hello everyone, my name is Dona Jayakody. I'm the research lead for the Cognition and Hearing Loss Project at Ear Science Institute, Australia. Today, I'm going to be talking about one of our clinical trials known as the HearCog trial. So before I talk about the HearCog trial, I'd like to give you a bit of background information. So hearing loss is the second highest cause of disability in the world, affecting 1.3 billion people. It is estimated that by 2050, 2.5 billion people would have some degree of hearing loss and 700 million will require hearing rehabilitation. There are a number of consequences associated with untreated hearing loss. They are increased social isolation and loneliness, mental distress, frailty, cognitive impairment, and dementia. So there are about 50 million people worldwide diagnosed with dementia, and it is expected that this number will go up to 131 million by 2050. Every 3 seconds, someone in the world develops dementia. Dementia has physical, psychological, social, and economic impact, not only on people with dementia, but also on their carers, family, and society at large. So in Australia, 400,000 people are currently living with dementia, and it is the second highest cause of mortality in older adults. So dementia of the Alzheimer's type account for 60 to 80% of all cases, and which is characterized by synaptic loss, neuronal loss, and brain atrophy. So how does one end up developing dementia? So healthy aging and cognitive aging is a very complex process. So as people age, some of the old adults start exhibiting increasing number of memory complaints. They're known as subjective memory complaints or subjective cognitive decline. So then there's a group of participants known as mild cognitive impairment or MCI. On a cognitive assessment, they would perform poorly. On an MRI or FDG scan, they would start showing the first sign of neurodegeneration. However, their daily living functions would be intact. When someone is diagnosed with dementia, their daily living functions would be affected. They will show signs of neurodegeneration on a brain imaging. And also, they will perform poorly on a cognitive assessment task. So in 2017, Lancet Dementia Prevention and Intervention and Care report looked at the modifiable risk of dementia and calculated that hearing loss contributes to 80% of the modifiable risk factors of dementia. Lancet report also estimated that a third of dementia diagnosis worldwide could be delayed or prevented with early intervention or changes to lifestyle. And if the risk factors could be reduced even by 10 to 20% per decade, the number of dementia diagnoses could be reduced by 8 to 16 million by 2050. So to summarize, our research has found that there's an association between hearing loss and cognitive impairment, and the degree of cognitive impairment increases with the severity of hearing loss. And age-related hearing loss also increases the incidence of dementia and Alzheimer's disease. So when assessing cognitive functions of old adults with a hearing impairment, we need to be very mindful that if the participants can't hear the instructions and they can't understand what needs to be done, they may not be able to perform well on a cognitive assessment task due to their hearing impairment. So it is important to use suitable cognitive assessment tools for the hearing impaired when we are assessing cognitive functions of the old adults with a hearing impairment. So in this study, we wanted to investigate the association between untreated hearing loss and nonverbal cognitive assessments. we recruited participants with normal hearing, mild to moderate hearing loss, and moderate to severe to profound hearing loss. And we measured their hearing, cognitive functions using nonverbal cognitive test battery, and depression, anxiety, and stress. Here's an example for nonverbal cognitive assessment test battery, and completing these assessments are similar to playing a game on a computer screen. So in this study, we found that untreated hearing loss is associated with episodic memory and working memory tasks. Then the next logical question was to ask what happens if we treat the hearing loss. So those who have moderately severe to profound hearing loss undergo a surgical procedure known as cognitive cochlear implantation. So in this study, we recruited the participants, cochlear implant recipients and cochlear implant candidates, and measured their hearing, speech perception in quiet and noise, cognitive functions, and mental health. We found out that after using a cochlear implant for 1 year, we saw significant improvement in episodic memory, reaction time, and working memory tasks of cochlear implant recipients compared to the cochlear implant candidates. Then we wanted to find out what happens if we treat the hearing loss with hearing aids. So for this pilot study, where we recruited 24 normal hearing listeners, 54 participants with a hearing loss but who were not interested in getting a hearing aid, and 38 hearing aid users. So we measured their hearing, speech perception in quiet, speech perception in noise, nonverbal cognitive functions, and mental health. So in this graph, the first graph, we have normal hearing participants, hearing loss, and hearing aid users. And we can see that after using a hearing aid for 1 year, we see a significant improvement in delayed matching to sample cognitive assessment scores. In this graph, we can see that after using hearing aid for 1 year, there's a significant decline in working memory errors of the hearing aid users. So based on this information, we designed a randomized controlled trial. The primary aim of this randomized controlled trial is to investigate whether hearing aids decreases the 24-month rate of cognitive decline in those who are at risk of dementia, those participants with mild cognitive impairment. We are also interested in finding out whether hearing aids have an impact on memory, executive functions, anxiety, depression, quality of life, physical health, and health-related costs over 24 months. So we aim to recruit 180 participants. They will be randomly assigned to 2 groups, 90 in the experimental groups and 90 in the delayed control group. So the participants in the experimental group will receive their hearing aids as soon as they complete the baseline assessment. And those who are in the delayed control group will receive their hearing aids a year later. So the eligibility criteria is older adults, 70 years and older. They do need to have a mild cognitive impairment and also hearing loss, and need to be eligible for hearing rehabilitation. So all participants complete a test battery at baseline, 6, 12, 18, and 24 months. The test battery includes global cognitive ability measurement using MOCA for the hearing impaired, nonverbal cognitive assessment, cognitive reserve index, health status and quality of life, physical function, depression and anxiety, daily living function, social support and interaction, frailty, and also the effectiveness of hearing aids. So during the intervention, audiologist conducts a hearing assessment and discuss the hearing aids and also their listening requirements. Hearing aids are then fitted and conducts a real ear verification and validation methods. 2 weeks later, there's another hearing aid review during which the changes are completed or done for the hearing aid programming. So if all goes well, the audiologist sees the participant at 12 and 24 months after the hearing aid fitting for a review appointment. Our research assistants contact all our research participants and find out how they are doing, if there's a problem with the hearing aid, and we immediately make an appointment for them to see the audiologist. We recommend our participants to use their hearing aids around 6 hours per day. We also take this information by logging into the data logging software of the hearing aids. As part of the study, we also conduct 2 types of imaging, MRI and FDG PET. Participants have an opportunity to either be involved in this imaging or not. So as you all know, hearing loss leads to changes in the brain volume and also the central auditory pathways. So we try to investigate whether by using hearing aids and treating hearing loss using hearing aids, whether we see any changes in brain volume and central auditory pathways. We do that by measuring the MRI scans at baseline, 12 and 24 months. We also have FDG PET imaging. So when someone has age-related hearing loss and cognitive impairment, there will be some changes in metabolic activity of the brain. So we measure this at the baseline and also measure it at 12 and 24 months after treating the hearing loss with hearing aids. So we are interested in finding out the characteristic patterns of metabolic activity in patients following the hearing aid treatment. So for this, we use 18F FDG PET tracer. So participants are being injected with a PET, FDG PET tracer, and about after 30 minutes, we take the images. So it takes about 30 to 60 minutes to acquire the images in this study. We also conduct a health economic analysis. So we are interested in finding out by whether treating hearing loss with a hearing aid, whether that leads to improvement in their overall health and well-being. If so, we assume that there would be cost associated with healthcare and would be less. So in order to find out that, we obtained the information from the Department of Health Data Linkage Branch in Australia, especially in Western Australia. All the hospitals are linked together. Data from all the hospitals are linked together through a data linkage system. So from them, we obtain the costs associated with pharmaceutical and Medicare-based costs, and also other costs such as mental health information, home and community care, emergency department data, aged care assessment, and St. John's ambulance. So all these costs are calculated, and then our health economist carries out quality of adjusted life year or QALY gained by the intervention. So right now we are in the process of recruiting participants, and we have to screen about 900 participants to find the 200 eligible participants for the study. So this process takes a bit of a long time. So this project would not have been possible without the funding from Oticon, Department of Health, Rebecca Cooper, and Royal Perth Hospital Foundations and grants. So we are very grateful for their funding. And also I'd like to thank the participants and my entire research team. We work very hard to find out whether we can delay or arrest the cognitive decline by treating hearing loss. And we are hoping to get the first results of the study by early 2024. And it's very exciting, and we are really looking forward to find out the outcomes of the study. So thank you for listening.